Our next session poses the question, what are my options in relation to therapeutics? Welcome to the stage, Dr. Asia McCutcheon. A round of applause, show her some love. A gastroenterologist at the Atlanta Gastroenterology Associates.
What's poppin'? Brand new whip, just hopped in. I got options. I can pass that like Stockton.
You can hit a little dance move, Asia.
So I can go ahead and start. Hello, everyone. Just want to say thank you for being here. What a wonderful organization. So excited to see some familiar faces. Matt, Thaddeus, and other people that have really changed the landscape of inflammatory bowel disease. So I have the task, as well as honor, of presenting the options for therapies in inflammatory bowel disease. And so it took me a while to get these slides over because I said, arguably this is probably one of the most important topics here today. But I'm excited to have a discussion around what our options are. And I welcome any questions at the end. So I'm Dr. Asia McCutcheon with Atlanta Gastroenterology here in Atlanta. About 30% of my patients are inflammatory bowel disease patients. I've been involved in patient advocacy for several years now, just based on the need to share and have shared decision-making and support in the community. So without further ado, we'll go ahead and get started. So what are my options? We're going to talk about therapeutics today. So our learning objectives today, we'd like to help you understand how we risk stratify patients with inflammatory bowel disease, review concepts of target to treat, learn about therapies and review a few mechanisms of action, and define ultimate goals of therapy. So inflammatory bowel disease, as all of us know, is a really complex interplay of environmental factors, immune responses, intestinal barrier dysfunction, as well as genetic predisposition. And so our therapies are not in a silo, but rather looking at this very complex interplay of all of the factors that are contributing here. When we think about Crohn's disease and ulcerative colitis, as a provider, we're often trying to figure out, okay, is this Crohn's disease? Is this ulcerative colitis? But it is important to note that multiple studies have shown that no matter what the inflammatory bowel disease is named, the impact is very similar. So there's a similar impact on the patient's quality of life. There's a similar economic burden. Both diseases can lead to burdensome complications. Surgery cures neither disease, which we used to tell patients in the past. I remember when I was training years ago, okay, if you have ulcerative colitis and you get a colectomy, then that's it. Well, that's not necessarily it. There's a lot of additional complications that can occur even after the colectomy. Similar monitoring needs to take place. Treatment goals are very similar. And our therapeutic armamentarium, that is our toolbox, is also very similar. We think of the disease in terms of what is the degree of bowel damage that is occurring? What is the impaired gastrointestinal dysfunction that is occurring? And then there's some mixed mechanisms. A lot of the studies have looked at, for example, what is the most bothersome symptom that a patient experiences that impacts their quality of life? And that is the anal rectal dysfunction, the urgency, having to know where every bathroom is on their way to work, having to take frequent bathroom breaks, and not knowing if they're going to have an accident, for example, when they're in the middle of a test. You can imagine your quality of life is severely negatively impacted by those things. So while we do want to place patients into categories, we know that we have to be careful because we have to look at disease impact as well. Now, we're here at COCHI, so I'd be remiss to not talk about the disparities, which I'm sure you've heard over the course of the day. We have tried to understand these in terms of structural contributors, social determinants of health, and individual behaviors. And so, we need to understand if we need to address things upstream, midstream, downstream, but really the patient should be the center of all of this. And so as we look at disparities that are driving inflammatory bowel disease, this is a nice diagram that shows us that there may be environmental differences, sociocultural as well as dietary habits that may be contributing. There may be phenotypic differences. Black African American patients may have more perianal disease, for example. There are differences in disease perceptions. There's a study that was done looking at depression and hopelessness and feeling like you have control in African American patients, and found that there was less thoughts of having control, like people didn't feel like they could do anything really in this particular disease state. There's differences in adherence, and we do not like the word non-compliant, because compliance, the definition for me may be different than what's actually happening. When a patient shows up and they have not taken their drug, perhaps it's because they didn't have the resources. Perhaps nobody, told them how that somebody mentioned before that they could file an appeal and actually get the medication that they needed. Perhaps they never even, came up with the copay at the pharmacy, and so forth and so on. Provider decision making. So we want to make sure, there was a mention of making sure that you connect it with the provider, because if a provider is biased as to what they're offering you, that can really negatively impact your entire trajectory here. Delays in diagnosis. The earlier you jump on inflammatory bowel disease, the better the outcome. And that is demonstrated across multiple studies. And it is also known that in Black and brown communities, there is significant delay in diagnosis that negatively impacts the disease. Differences in insurance company, that was alluded to earlier. Access to inflammatory bowel disease specialists. If we're in communities and there is no GI specialist around, then, or there's, a 6-month wait and you're sitting up there bleeding, then you have increased risk of hospitalizations. And then there may be some genetic differences and so on. So we have this concept of treat to target, and the first thing that I do when I have a patient with inflammatory bowel disease is sit down and try to have a discussion around what our goals of therapy are. And so that comes with a couple of domains here. So first, we want to make sure we have an accurate and an early diagnosis. We want to understand the disease phenotype. We want to determine what your prognosis is based on how you're presenting. And then we want to assess for something called extraintestinal manifestations. Inflammatory bowel disease does not affect the gut. We all know now, with social media and forums to support each other, that the mind and the gut connection is strong. 70% of your immune system is here. Most of your serotonin, your feel-good hormone, is produced in the gut. And so there are other manifestations. This disease, and it's a dis-ease. It can affect your eyes. It can affect your skin. It can affect your mental health. And so we need to assess for all of those factors. We need to look at the indications of remission. So I tell patients, there is this inflammatory process that's going on, and we need to turn it off. Shut the faucet off. We want to restore a sense of well-being, and then we want to normalize your labs, your growth, your nutrition, especially in children. And then we can't just let people go on off into the wild once we accomplish these goals. They have to maintain remission. So what is the definition of remission? And that is stable disease control and optimization of therapy. And then we want to make sure we have a sustained and durable response. I can't tell you how many times I'll get a medication refill request from somebody, and I haven't seen them in 3 years. I have no idea whether they're in remission, not in remission, and it is really kind of appalling to me that is not an alarm for the pharmacist that's requesting it, the medical assistant that sent it over, and everybody else that allowed this Swiss cheese to happen. And then finally, disease monitoring and prevention. So monitoring for early and subclinical relapse is a part of the treat to target. constantly reassessing patients to make sure they're good, monitoring therapies, preventing infection and cancer. A lot of our therapies are not without risk. There is some risk when we're manipulating the immune system. And then considering the long-term consequences of chronic inflammation, the same question we ask about the effects of treating the disease, we need to look at the effects of not treating the disease, and we need to be able to have that discussion as well. Now, there's this concept of whole care, and whole care should absolutely be the approach these days. The whole care approach is not just looking at the patient and their symptoms, but it's looking at the patient and the entire team that should be rallying around them to support them and make sure that we achieve health equity, which is optimization of their entire healthcare journey. And so with the patient being at the center, we need to involve our mental health care workers because we know about the psychological effects of this particular entity. We need to involve our social workers to make sure that our social determinants of health that are going to potentially impact their outcome is there. We want to make sure that their PCPs and surgeons are aware of what's happening at them at various stages of their journey. We want digital health care for them to be accessible. How do I know this is a hemorrhoid on my butt if I haven't seen a picture of a brown anus? Like, I don't really understand how we can not have representation in digital healthcare, digital images, and so forth. We need to talk about insurance companies, their involvement, their role, as well as some of the pharmacies that are controlling the prescriptions, and then dietitians need to be a part of this whole care therapeutic approach as well. So all of these components are important as we talk about therapies. Now, this is an exhausting list. This diagram is very busy, but the purpose of this particular diagram is to really highlight the different attributes of Crohn's disease and ulcerative colitis and try to understand their importance. So I'm going to skip this, but basically the overarching theme here is that there are physical effects that we can measure. There is medication use that we're looking at. We're looking at labs to see what your inflammatory markers look like. We're looking at protein levels, not just as a marker of nutrition, but to understand if a particular therapy is going to work for you, because some of these therapies do need to bind to protein to be effective. So if you don't have enough of that circulating protein, or if it's leaking, then perhaps the drug delivery is going to be impaired. We're looking at anemia, because that in and of itself is an independent prognosticator of how you're doing. Abdominal pain and steroid use. I don't know if anybody in here has had roid rage, but steroid use, while it is, it's a double-edged sword. And so it is helpful in terms of getting people into remission, but it's certainly not without side effect. So the next couple of minutes we'll spend talking about specific therapies. I want to remind everybody that I like to think of this as like 3 buckets of treatments for inflammatory bowel disease, and we're going to focus on the first bucket, which is immune modification, specific pharmacologic therapies, but there's also microbiome manipulation. I've had people ask me about whipworms, fecal transplants. When people are living with this disease, we will do almost anything to have a normal life. I heard Kim Kardashian say she would eat poop if it helped her to stay skinny. I'm sure my patients would eat poop if it helped them to cure their inflammatory bowel disease. We know that there's billions of dollars being spent on prebiotics and probiotics. So are they legit? Are they real? Do they help? Dietary therapeutics are also a part of especially Crohn's disease in terms of trying to manipulate the intestinal gut bacteria, which you've heard about today and you'll continue to hear about over the course of this conference. And then surgical interventions are a part of our therapeutic treatment options. When people have advanced scars, it's like you can put all the drug in the world on a scar. A scar is a scar is a scar, and it's probably not going to open up once you've gotten that far. And so sometimes you do have to perform surgery, and patients will feel much better. And then if they have perianal disease, sometimes they have to have surgery as well. So for all intensive purposes, we're going to continue throughout the rest of this talk to talk about immune modification and specific pharmacologic therapies. Now, how do we choose a therapy for induction? We've heard from this panel, and we heard that we don't need to throw treatments at people, but we need to work with people. And so there is this entire concept of a shared decision-making model. And that shared decision is your provider bringing their expertise to the table in a non-biased way and sitting down with you and understanding what your preferences are, what your beliefs are, what is available to you, and what you are okay with being treated with, and putting that all together, and that is the shared decision model. So while this is talking about therapies and is sort of objective, we need to take that into consideration, that is absolutely a crucial part of deciding which therapy is going to be best for a patient. And so from my standpoint, I'm also objectively, based on the evidence, looking at disease activity, your likelihood of clearance, if I can be organ selective and not just throw, for example, something that's going to affect your whole system, but maybe I can be a little bit more gut selective and minimize your side effects, then we'll go there. I will at least offer that. I like to offer 2 therapies and then give a patient an opportunity to go home, think about it, talk about it with their family, research it, and then come back to the table like it's no pressure, because this is a decision that we need to be able to live with. We need to talk about comorbid conditions. So what other things do you have going on? Sometimes people don't just have Crohn's disease. They have psoriasis. They have rheumatoid arthritis. So there may be therapies that we choose based on them having not just one thing going on. And then a history of cancers or infections should be taken into consideration, because a lot of what I'm going to show you may increase the risk of cancers and infection, and it's because we need to manipulate the immune system. And so these are some of the oral and skin manifestations. You can get lung disease associated with inflammatory bowel disease. Sorry for the graphic nature of these pictures, but imagine if you were the one that had it. So we need to see this. Now, the way that we kind of approach patients is we try to understand their disease prognosis and severity early on. And so we do like to understand, are our patients a low-risk patient or is this a high-risk patient? And then we need to react to that. And so a low-risk patient for a colectomy is defined in ulcerative colitis as somebody that has limited anatomic extent or mild endoscopic disease. And then those that are high risk are those that have an extensive colitis, or what we call a pancolitis, so it's involving the entire colon. They have deep ulcers, they're young, they've already had hospitalizations, they're steroid dependent, high inflammatory markers, and if they present to me with a C. diff infection early on, I know we need to be aggressive. So C. diff is a nasty bacteria that you may have heard of, and the risk is increased in inflammatory bowel disease, even in the absence of having antibiotics. And it really made me upset the other day when I had a patient that had inflammatory bowel disease that went to the hospital and came in, and I said, well, did they check you for C. diff? And she said that the doctor said no because she had not had antibiotics, and I almost lost it. All right, so Crohn's disease risk stratification. Similarly, we do a low and a high risk. So our low risk patients are, and this is based on the data, this is not an absolute. Nothing in IBD is an absolute. That's the problem. So, but a lower risk patient is those that have an age at initial diagnosis of greater than 30. Their ulcers are superficial, not deep, no prior surgeries, no strictures, no penetrating features, and they have limited anatomical involvement. That patient tends to do better than somebody that has a younger age at diagnosis, more extensive involvement, deep ulcers, has already had prior surgeries, stricturing or penetrating disease, and then perianal and severe rectal disease. perianal disease is debilitating and embarrassing in and of itself for our patients, so we need to really assess for that and be very aggressive, because if we want to optimize their health and have them, not run away and isolate and have all kind of sequelae of this, we need to understand what it is and be very aggressive. So that is a reason for the risk stratification. And then additional considerations. We talked about how there can be overlapping immune conditions. What is the degree of disability? Just because I don't see a ton of ulcers in one patient does not mean that they are not being negatively affected every day the same way that somebody that is requiring surgery may be affected. So everybody's perceptions are different. Everybody's tolerance is different. And so we need to understand the degree of disability here. What is the burden of inflammation? What is the mental health state? That can determine a lot of things with the patients. And then what does the diet look like? Because all of these genetically modified foods, all of this fake stuff that we're taking in, that can affect your gut. But what we do know is that damage occurs very early in inflammatory bowel disease, and so the earlier we can intervene, the better the outcome. This is showing you on this graph exactly what happens over time. So the disease onset is called the preclinical phase, because a lot of times we don't get to the patients just yet. And then a few years later, 2 to 5 to 7 years later, depending, the diagnosis takes place. By this time, when it's clinical, we are already potentially starting to see some of the effects of inflammatory bowel disease. We're starting to see strictures, we're starting to see abscess, we're starting to see fistulas. For those of you that don't know what a fistula is, it's a connection between two areas that should not be connected. You can have them between the bowel and the bladder. Sometimes people are having vaginal flatulence and all kind of other things going on, drainage, having to put bags on the abdomen. Surgery, anybody that has had surgery knows it's a really big setback, but sometimes it's necessary, and strictures where you have areas of severe narrowing. So if we can reach people in the preclinical stage, we can truly, truly change the trajectory. So let's talk about our therapeutics. This is a table that is comprehensive. The landscape continues to change in terms of our therapeutic option. It is not by all the end-all, be-all, because there are studies going on now. Our practice has some ongoing studies. There's lots of studies out there. But this is just showing you some of the treatment options that are available that have been FDA approved thus far. And so for Crohn's disease, there are ongoing studies about dietary interventions and treatment. But again, I told you we were going to focus on the immunomodulator therapies. 5 ASAs that are indicated for ulcerative colitis for induction and maintenance in mild disease have been around for about 80 years. So we've got lots of experience with that particular therapy, and it is considered a conventional therapy. And then steroid therapy, which is this non-specific therapy. The receptor is expressed in tissues all over your body, so it's not only going to affect your gut but everywhere else, but it does work. And then antibiotics, maybe not a clear role in terms of induction and maintenance, but there are other indications for antibiotics in patients that have had surgeries or patients that have perianal disease. Thiopurines or immunomodulators, which includes methotrexate, are indicated for Crohn's disease, and then we use thiopurines for ulcerative colitis. But there may be other conditions that you have, like if you have rheumatoid arthritis or psoriasis, and some other neoplasms that we may use this methotrexate in. And then getting into our biologic therapies and our small molecules, we have alpha integrins, which is vedolizumab and natalizumab, and those are working in both induction as well as maintenance therapy. And we initially used natalizumab in MS. Our anti-P40 therapies or IL-12/23 therapies, specifically the initial one was targeting the P40 subunit. We have a newer therapy that is targeting just the IL-23 subunit and is a little bit more specific. And so there are other indications for that particular one as well as to why we may choose that one. Our anti-TNFs, those have been around for several decades now. Those have really shifted the way that we treat inflammatory bowel disease as well as some of the negative outcomes that we've seen. And so we were ever so grateful. I have a gastroenterologist that is probably 76 or so, and he said, you know what, Asia, when I was in training and fellowship and early in my career, all we had was steroids for the patients, and then we had the immunomodulators, and it was just a terrible, terrible disease to have. And so we are ever so grateful for anti-TNF therapies and everything that's come behind that. And I also say that from our therapies, when they hit the market and we, have experience with our patients, we also can learn more about inflammatory bowel disease. So not only are we treating the patients with these therapies, but we're learning about the disease and how it responds. And then we've got our small molecules. We've got a class of therapies called the JAK inhibitors. And in this particular category, we have tofacitinib, and UPA is not listed here, but TOFA was a non-selective JAK inhibitor. And then UPA came out next, and we're trying to be as selective as possible, so it's just working on the JAK1. And then our S1P modulators, that's the newer kid on the block. That one is ozanimide, and that one is working on leukocyte trafficking, specifically on the lymphocytes, and it has been indicated for UC and has been used for several years in MS as well. So this shows you the complexity of what we're trying to target. Like this particular slide is actually, is there a pointer on here? Let's see. Whoops. So this slide is really highlighting, though, the complexity of the immune system. So every day we are presented with different pathogens. We live with bacteria. I used to tell people for every gram of stool, there's 1 billion bacteria. We live with yeast every day. We live with fungi, and our bodies are usually lined up tight like soldiers to prevent us from being affected by those. When something does get in our system, we activate our immune system. We have 2 major pathways in our immune system. We have the innate immune system, and that is like, I like to think of the wild cousin down the street. Whenever something's popping off, she doesn't care who it is, what it is. She doesn't think about anything. She just comes out. That's the innate immune system. And then we have our adaptive immune system. That's the one that's like, okay, let me judge this. Let me see what it is. I remember this. This is how I respond. And so those are the 2 that are at play here. It has been, and then we have these protective layers on the top of our gut or in the lining. And so we have a mucus layer, and that mucus layer is also protective. And that mucus layer is thought to be impaired, or has been shown to be impaired in inflammatory bowel disease. And then what also is happening with inflammatory bowel disease is our soldiers are not lined up tight anyway. There's holes in the team. So things can get in. And then what happens is the non-selective, the cousin comes, okay, and makes everything worse, and then confuses our adaptive immune system, and so it just becomes this poorly regulated inflammatory process. So we talked about 5 ASA therapies, which is really trying to, at a very surface level, control the inflammatory process. So decreasing the inflammatory markers or the cytokines has been used for over 80 years. You may have heard of sulfasalazine. That's the prodrug. Not everybody is tolerant of sulfasalazine, though. There are a small group of patients that will have the opposite reaction and actually flare with this particular therapy. It does decrease the production of cytokines. It is considered a conventional therapy, and sometimes the insurance company does want us to fail conventional therapy before we can move on to something bigger and better. One thing that I'll also say is, well, let me tell you this first. The drug delivery differs, so there's different formulations of the 5 ASAs, and it sort of depends on where your disease is most active. This is in ulcerative colitis, for example. If you just have limited distal rectal disease, which is right there at the end, even though it's just that last little part, it's right there at the sphincter, so people have a lot of urgency. They can have bleeding. It doesn't mean they're not affected, but with that, you can hit it from below. I didn't mean to say that. Let me take that back. Sorry. Target it from below. And then you can actually just, you can treat it with topical therapies, foams, and so forth. We have to be careful in GI because it's, what is it? Too many double entendres, so we can look that up. And if we have disease that is more on the right side or pancolitis, we want to give oral therapies as well as rectal-based therapies. So the delivery mechanism of these drugs, which are acting more topically, depends on what area of your colon is involved. As we look at biological therapies for inflammatory bowel disease, the treatment options are really trying to target the very complex immune system and the inflammatory markers that are taking place. So some of our therapies are targeting TNF. TNF is a pro-inflammatory marker that once it's turned on, it activates a lot of additional, it kind of recruits a bunch of additional cells to kind of act with it. And so you're probably familiar with infliximab, adalimumab, certolizumab, and golimumab. And early on, the infliximab, which is still a fan favorite, because we know it works and it's got a pretty long, nice track record at healing fistulas and things like that, that we had to watch for some interactions with that when people were getting infused because it was half mouse, half human. Since then, a lot of our antibodies are actually humanized antibodies in that particular space to try to decrease the risk. And then we've done lots of fancy things to try to get the drug to stay around a little bit longer. We've tried to pegylate it and all of these things, which is where we sort of, chemically modify the structure so that it has a better efficacy. Ustekinumab or Stelara is the trade name. You may have heard of that. That's working on IL-23 and IL-12. The reason these were the targets is because these were early on shown to really activate the T cell cascade. That's a part of that adaptive immune system. That's the one that actually has some home training. And so that particular drug came out, and then there's another more specific drug that's come out since that time, which is Skyrizi. You may have seen commercials for that one, and that one is targeting specifically the IL-23 subunit because there were some potential concerns in the lab about having both the IL-23 and 12, with the 12 potentially increasing risk of infections. I don't think that I don't know if that's actually panned out. There may be more data emerging there, but certainly, when ustekinumab came out, we were ever so grateful. It's a great therapy, and it's a great option. And the important thing here is as we make a decision about what we're going to use, not everything works for everybody. So the main thing is, again, the shared decision, what we can get access to, and hopefully get onto something that works. These small molecules, the tofacitinib is working on the JAK-STAT pathway. These are sort of affecting gene transcription that then tells your body, okay, now we got to act. So they're working at the transcription level and cellular signaling level. And since TOFA has come out, UPA has come out as well. So we're trying to, again, be as gut specific as possible. There are these leukocyte trafficking molecules that are out there as well. And so this is the way that vedolizumab works. There are, on the gut lining, there are these cells where when your immune system is activated, it binds to the white blood cells in your system. And so this is interfering with trying to decrease the binding there, so those cells don't get into your colon wall and set off the inflammatory process. And then the newer kid on the block is, we've already talked about the interleukin, the S1P receptor modulators, and what those are doing is basically saying, hey, we're not even going to go there. Keep that cousin in the house. You can't even leave the house. So it's basically sequestering those lymphocytes in the lymph tissue so that they can't even sense that there's a problem. So that is the mechanism by which the S1P receptor modulators work. You'll see a laundry list of names here. There's lots of drugs that are being developed and underway, and there's not a one-size-fits-all here. It depends on your situation, what we can get for you, what you're willing to take. We look at side effect profile, and we make a shared decision. So what we do want to emphasize here is that the earlier we intervene, the better. I want to make sure you take that home. We want to make sure you get your diagnosis in a timely manner, that you don't have somebody that is dismissing rectal bleeding for hemorrhoids, which we see all the time. We know that we have a therapeutic window of opportunity. Almost all of these studies have demonstrated that if we start on a therapy, especially in advanced therapy, that our first therapy is probably our best chance. And after that, we start to lose momentum in terms of what's going to work. So we want to choose wisely at first and make sure that we have very tight control. And we want to do that based on risk stratification, our safety profile, our patient preferences, and our reimbursement policy. And then we want to be tight with our monitoring. We don't want to just say, okay, that worked, you're good, have a great life. We want to actually continue to monitor patients. We want to look for not only clinical remission, but mucosal healing. We want to look at, from a physician standpoint, I want to know what your biomarkers are. Are your inflammatory markers still elevated in your blood? Because if so, there may be something going on even though you feel better. Are your stool markers elevated? That's called the fecal calprotectin. And then looking at transmural and histologic healing. So we used to be okay with just looking and saying it looked good, but now we want to make sure that your biopsies also look normal. We want to get as close to normal for you that we can get. And then in the future, there's been a lot of work. There's this international organization on the study of inflammatory bowel disease, and they've been helping us to really define endpoints going forward. And so in the future, the trials are going to focus on the regression of impact in a patient's life. How is their quality of life? What is the level of disability? That fecal incontinence that I told you was the most bothersome symptom. Has that been eliminated? Is there a regression of disease complications? Is the bowel damage gone? Have we eliminated IBD-related surgeries? Have we minimized or eliminated hospitalizations to zero? Have we made sure that we have not had any extension of our disease? Have we looked for extraintestinal manifestations and made sure that those are gone? Do we have any evidence of short bowel syndrome? So we want to prevent all of these long-term complications and make sure that we restore a normal quality of life. So again, our management goals, we are going to define the extent of disease severity. We want to induce a clinical remission, we want to maintain that remission, and we want to provide an improvement in quality of life and be a part of that team. This is another busy slide, but this is just showing you kind of how we position our therapies. If it's a low-risk patient, for example, we may position our therapies slightly different than a high-risk patient. For the sake of time, I'm going to go on to the high-risk patient. Remember, in the high-risk patient, we're looking at the risk of disease-related complications, we're looking at the risk of treatment-related complications, and then we're also looking at our patients' values and preferences. And I think in terms of what drives disparities, we're real good at looking at, the disease-related complications and the potentially explaining the treatment, but we don't take a lot of times patients' values and preferences into consideration. But those are all very important, because if I think I did you some good when I prescribed you infliximab and you never showed up because you talked to your relative when you got home and they were concerned about cancer, and I didn't know it until a year later, then we haven't really made any progress. And you weren't also the center of that discussion. So with severe disease, we do have some therapies that we may go to first. We may go to infliximab first or do some combination therapy. But we follow very strict guidelines in terms of what we offer you. So we're not just pulling it out of thin air like, okay, let's just do Zeposia. Like, it's not like that. We actually base it on some evidence. And then, again, we try to risk stratify you because we want you to have the best opportunity possible. This is another diagram kind of helping clinicians to understand what the treatment algorithm should be if a patient has moderate to severe ulcerative colitis. And this is basically giving you various therapeutic options and essentially telling you as well what your first-line therapies may be if a patient is biological naive, or if you have somebody that is a prior failure of infliximab. And we have changed the way that we look at drug failures. We used to say that the patient failed the drug, but now we're saying that the drug failed the patient, because that's actually what happened. That most of the time the drug failed the patient, and we just may not have found the right mechanism of action for that particular patient. And that's why it's so important to understand that we do have a nice toolbox, and what may work for one person may not work for the next, and we need to understand the full clinical picture. And that requires us to assess and reassess and have frequent visits and have a relationship. We do use validated scoring systems when we're trying to understand how a disease is impacting you. So for ulcerative colitis, we use a Mayo score. This is looking at stool frequency, rectal bleeding, the findings on endoscopy, and then the physician's global assessment is it's a subjective measure of how you're doing based on your quality of life and so forth. And then in Crohn's disease, for example, especially in the studies, there are some indices that we use as well. There's a Crohn's disease activity index, for example, and it's again a scoring system so that we can, as objectively as possible, based on your disease presentation and what your complaints are and your quality of life is, kind of understand what you're experiencing. So when we have a patient, we're looking at their age, their family history, their gender. Are they going to have kids? There are some of the therapies that may affect, childbearing. And so we want to understand that. Have you had a previous surgery in the past? Are there plans for pregnancies? There are, for example, with the S1P receptor therapies that I was telling you about that keeps those lymphocytes where they need to be and shuts the door. Those particular therapies, you don't want to give those in somebody that is, potentially going to have a baby. They may be teratogenic and have some toxicity there. So it's very important to understand that. You want to assess the phenotype and any coexisting conditions. So I want to know if you have anything else that I need to treat, because maybe this one therapy that I'm going to give you will not only take care of your Crohn's disease, but it may also take care of your psoriatic arthritis. So we need to know that. We need to assess disease activity often and frequently. We also need to empower the patients. Ask about the patient's goals, educate them, ask about risk and benefits, and then consider therapy preferences based on what we learn about what you like. I can tell you in 2 minutes if I have somebody that wants to do natural therapy. They'll come in, they'll tell me their experience, and I'm like, you want to do natural therapies first, right? Okay, that's fine. I'm going to give you 4 weeks. We're going to do this natural therapy, and then we need to come back to the drawing board. So respect their wishes, but understand who you're dealing with. You want to consider national guidelines, and you do have to take into consideration what our coverages are. You want to select, adjust, or change therapy if needed. And all of these therapies in that International Organization of the Study of Inflammatory Bowel Disease, they nicely tell the providers when you can expect a response. And there are some people that may have a slower response, but in general, it's a really nice table to share with people to say, like, hey, when can I expect my rectal bleeding to decrease? When can I expect to feel better? And your doctor should absolutely know that. And nobody reads the book. That's what we say in medicine, so it's not perfect, but it is at least a guide, and it is something that if your patient is not responding in the way that we expect them to respond, that we need to act on. So understanding treatment goals, monitoring we talked about, potentially de-escalating therapy is always a hot topic. People want to know how long they're going to be on the therapy. We do have to tell people that this is a chronic relapsing and remitting disease. So if we want to accomplish that goal of, you having a great quality of life and optimizing your health, then we probably need to stay on something lifelong. And so we do have to have that discussion. There is some consideration for drug holidays and looking at flares and complications. So we have our therapeutic goals, our clinical goals. Endoscopy is a part of this, seeing whether we see any active disease, biopsying, making sure that the histology looks good. That's where we send it off to the pathologist, combining that with imaging and labs, and then what our patients are living with, because the patient is, again, the center here. So when we're doing this thing called treat to target, we are basing this on these sort of consensus and expert-guided therapeutic goals. And for Crohn's disease, for example, we want a resolution of abdominal pain and normalization of the bowel habits. And then we want endoscopically, in absence of ulceration, that should be a target. Endoscopy or cross-sectional imaging should be performed within 6 to 9 months after treatment starts. We want to achieve, if we can, histologic remission, but that is not necessarily a target because, not right now, but it is in ongoing trials, but we are concerned that if we say, okay, you have to be perfect by histology, by biopsy, that we may start running through therapies a little bit quicker. But we are pleased, and we know that histologic healing does correlate very nicely with somebody continuing to maintain that remission. And then we want to assess outcomes at least every 3 months until resolution. And then after symptoms are resolved, they can't go for a year. They should be assessed at least every 6 to 12 months. So this is showing you how we've changed our thought process in terms of treat to target with the STRIDE and the SPIRIT. So we look at clinical response and clinical remission, yes, but we also want to understand and normalize our biomarkers, and we want endoscopic healing and normal growth. In terms of our disease modification and long-term modifications that we're looking for, especially in clinical trials, we want to restore a normal quality of life. That is critical. We want to prevent disease complications from occurring, including cancers and infections, and then we want to reduce our long-term complications. So we used to just, historically just look at, okay, the patient's feeling better, we don't see anything, that's great, but we are looking deeper. We want deep remission now, so that is key. So in conclusion, IBD is a whole patient disease, and that requires a targeted individual approach in which the patient should be center. We want a shared decision-making model to be a part of what we decide to treat with. There are many therapeutic options available, and many are in development, really trying to target various aspects of the immune system. We do not pull these things out of thin air. There does need to be some evidence-based guidance on this and patient clinical factors to determine which treatments we're going to start with, and treating to target is optimal. Thank you. I'll take any questions. Yes, ma'am. Yeah, so that's a great question because depending on what you're treating, there's actually a difference, and I'll give the table to Melody because there is a difference depending in terms of how quickly you will respond based on the disease that you're treating. So for example, even though we use ustekinumab, for example, in ulcerative colitis and in Crohn's disease, there is a little bit of a time difference in terms of when to expect a response, and I should have put that in here. And that also applies to your rheumatologic or some of your other autoimmune diseases that you're treating. There are several therapies, though, that are out there that target, other autoimmune diseases that I showed you on the table. And I will tell you that in GI, we tend to be a little bit more skittish. So usually the rheumatologists are actually ahead of us with their experience with a lot of these therapies. We wait and see. We're like, okay, all right, okay, they seem to be okay with prescribing this. And then at least in the community, then we'll kind of jump on the bandwagon and start prescribing it to our patients. So usually, and the best approach is a multidisciplinary approach. And it kind of depends on, in terms of educating you on what you can expect in timeline. What is sort of the driving factor? Is it your bowels that's kind of driving this? Because the other thing that can happen in inflammatory bowel disease is some of the arthritis and so forth is not necessarily a primary disease, but it's more related to the gut inflammation. So if you understand based on these charts, without getting too specific about, which therapy it is, if you understand kind of what the driving factor is, if it's an extraintestinal manifestation and we heal your gut, in 4 to 6 weeks, then your arthritis may be better already, even though it may say on the label or, based on the studies that it may take 8 weeks to heal your arthritis. You're welcome. All right, thank you.